Welcome to PharmacyToDose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. Each episode, we summarize the available evidence, discuss controversial issues, and provide practical take-home points with a subject matter expert. I'm your host, Nick Peters, and wherever you are and however you are listening, thank you. Now, before we get started, just a small update on the book club that was announced on the last episode, ARDS. So a lot of us, I think, have New Year's resolutions, and many, including mine, probably include reading more books. So to assist with some resolutions and those types of things, Andrea Sikora Newsom and I will be co-leading a book club for friends and listeners of the pod. So we'll be utilizing Goodreads, which is like an online community for book lovers, and Twitter for the majority of the discussion. So if you're interested in joining, there's a Goodreads book. So if you go to, or a Goodreads group. So if you go to goodreads.com, simply just search PharmacyToRead, that's TOREAD, and join the group. So as a reminder, we're going to look to read about 4 books through 2020. And these will focus on, personal and professional development for the critical care healthcare professional. So there's tons and tons of good options for the first book, but Andrew and I narrowed them to 4. And we're going to definitely let the listeners, you all, choose. And so the 4 options are 12 Rules for Life, Dare to Lead, Essentialism, and The Infinite Game. So we have a Twitter poll out. You can vote for your favorite there, or you can simply email pharmacytodose@gmail.com. The book club is for the listeners, so we want and value your opinion. Now, the real reason we're all here today. So today I'm very excited to be joined by a friend of the pod, Amy Dzierba. Now, Dr. Amy Dzierba is a clinical pharmacist in the medical ICU at New York Presbyterian Hospital, Columbia University Irving Medical Center, and an assistant clinical professor of pharmacy services at the Columbia University School of Nursing. She completed her undergraduate work and Doctor of Pharmacy degree at Midwestern University School of Pharmacy. Thereafter, Dr. Dzierba completed her PGY1 pharmacy residency at Grady Health System, followed by a postgraduate year 2 pharmacy residency in critical care at the University of Washington Harbor View Medical Center. And she is here to share some of her expertise on extracorporeal membrane oxygenation, or Ecmo. Amy, thanks so much for joining me today.
Oh, thank you so much for having me. It's such a privilege to be part of this.
Now, growing up in Buffalo, I have to ask, so if anyone is going to get buffalo wings from your hometown, where should they be going? Where do you direct them if you get that question?
Well, legend has it is that the chicken wing actually did originate in Buffalo, New York, by Teresa. Frank and Teresa owned a restaurant downtown Buffalo. It's called the Anchor Bar. And so anybody who wants to try buffalo chicken wings, I do refer them to the Anchor Bar. You get the whole story. You can actually buy the sauce. In fact, my colleagues, when they know that I'm driving home to Buffalo, they always put their orders in for me to bring back the buffalo chicken wing sauce from the Anchor Bar. There is a rivalry, though. Duff is outside of Buffalo, but they are pretty competitive with the Anchor Bar's chicken wings as well.
So do they call them chicken wings or buffalo wings? I feel like it's chicken wings, but when I'm talking about buffalo, I feel it instinctively I call it a buffalo wing.
We're super lazy. We just say wings. Pizza and wings and the blue cheese sauce.
I'm working. My wife has become a vegetarian, so in solidarity, I'm working to become one. But those are the things that definitely will miss and will make that a little bit challenging. I imagine when you go home and get that sauce, you're the work kind of queen, right? Everyone loves that.
Yeah. In fact, I don't routinely go to the Anchor Bar because it's always so crowded. It is a little tourist trap. But my cousins and I actually went there this year. It was pretty quiet and tame, and we enjoyed some chicken wings. It was nice.
Now, you seem to have been infected by the travel bug, kind of going to lots of fun places. What would you say is the favorite destination you've been so far?
Oh, that's so tough. I do try to make at least one big trip every year. I have to say my top trip was South Africa, seeing the animals in their natural habitat, which is literally lions, tigers, and rhinoceros, giraffe, everything. It was pretty amazing, pretty incredible. My second favorite trip was Cuba. My friend and I who went actually ran out of money while we were there. We knew we couldn't use credit cards. We knew we couldn't use debit cards, but we didn't bring enough cash. And by day three, we had to set a bit of a plan and how we were going to spend our money. And that really was composed of eating a Cliff Bar for breakfast, a Cliff Bar for lunch, and then we got to spend money for dinner.
So it was like you were back to being a resident again. That sounds like a resident in a conference type of diet there.
Very true, but it was really fun because we used our money wisely. We actually we walked a lot more instead of taking taxis, and we got more of the culture that way.
Oh, that's so you turned a negative into a positive, making lemonade out of lemons. I like that. So pre-recording, I asked you about your favorite artist or band, and you answered Annie DiFranco. So what songs or maybe albums would you recommend to get the listeners interested in her music?
Yeah, I'm not sure many listeners will know Ani DeFranco. She's a bit older. She was really popular in the 80s and mostly the 90s. She's, I guess, a folk singer, I guess you would classify her as. But I really have a soft spot in my heart for her. She grew up 2 blocks away from me, and she used to do acoustic on rooftops. And she's from Buffalo, obviously. She also started a record company known as Righteous Babe Records. And so it's really hard to pick one album, but if I had to, I would say Little Plastic Castles is one of my favorites. She recorded that when she moved to New York City and was starting to make it quite big. But some of her older albums do have references to Buffalo, so I guess it's a little nostalgia for me also.
I mean, her voice is absolutely beautiful, and I'm a big fan of kind of the acoustic rock, almost a little folky in some of them that I listen to, and the Little Plastic Castle was a song that really stood out to me. So that's I high recommendation for everybody, especially if you're into the more of the acoustic, or a little bit, at least the songs that I listen to, a little bit of a slower kind of pace.
Yep.
Now back to the real reason that we're here today, talking all things ECMO. So how did you start to get involved, with ECMO and kind of gain an interest in patients on ECMO and researching it?
Yeah, thanks for asking that question. This kind of was an evolution of how ECMO went from cardiac ECMO into more respiratory ECMO. And many hospitals, although they've adopted using respiratory ECMO, their patients still will reside within a CT ICU or a cardiac ICU, where when we adopted respiratory ECMO, it really went to our MICU. And I had no idea how to care for these patients. And this was about 2007. We had our first patient. He was a 40-year-old man who was initiated on ECMO, who had severe respiratory failure secondary to influenza, and he had failed all of the therapies that we have that you just recently talked about on your last podcast for ARDS. And so we put him on ECMO. We put him in the medical ICU. And I didn't know anything about this, so I was scurrying around looking at PubMed, trying to figure out what this device is doing, especially since I noted that his sedation was exponentially going up every hour and he was still wide awake. Until we got him finally to a RAS of -5, I'm going to say these numbers, and they are correct. He was on 50 milligrams per hour of hydromorphone and 60 milligrams per hour of midazolam. And he finally went into a coma state where he was synchronous with the vent so that we could protect his lungs and give him low tidal volume ventilation, etc. And that just blew my mind. I mean, I was so nervous. I practically stayed overnight trying to read about this, figure out what is happening, what are we doing. Whenever I tell the story, I'll tell people your jaw should be on the ground at this moment, because outside of maybe status epilepticus, I've never used those doses of midazolam and never would fathom using those doses of hydromorphone because of the side effects. But that's what he needed to get through. I started perusing the literature, and there was a lot in the pediatric population because they had been steadily using Ecmo since its real inception. But there was very little published and with older technologies. But anyway, I applied what I was learning, and it kind of made sense a little as to why he needed this much sedation and analgesia. So that was one thing we learned. The second thing we learned is as he got better and we started taking off his ECMO support and putting him back on the ventilator, we were also weaning his sedation. Well, prior to decannulation, he was wide awake. Well, I won't say wide awake, but he was awake and purposeful. But then after decannulation, we didn't change his doses, and he completely went back into a coma. And it didn't hit us until several hours later. Well, we took the nidus away that was maybe sequestering this medication, and now we're giving him these massive doses. So we quickly fixed that. And then he woke up and he walked out of the ICU. He's one of our spokesperson for Ecmo from Colombia. And it was just a notable case because we learned a lot. That really drove the impetus for us to do some of the research that we've published on Ecmo. It was a pivotal case, at least for me.
I mean, the two things that stand out to me are the doses that you just referenced. I think even our neuro ICU colleagues' jaws hit the ground there. But then also, when somebody is, 40 years old, right, in the first half of their life, and seeing them decompensate that quickly, and if you're able to have such an awesome save and really good care, those things stay with you. So what exactly is ECMO? And, when did we begin to kind of start using this therapy here in the U.S.?
Sure. ECLS, or extracorporeal life support, in its actual application is really just an evolution of the heart-lung machine, or cardiopulmonary bypass, that was first used in cardiac surgery in the 1950s. But when that was developed, it was really developed for short-term use. And wasn't meant to be a little bit more long-term as we see the application of ECLS today. So over that time, they had to make changes to the cardiopulmonary bypass circuit to allow for this more prolonged support by reducing the surface contact between the blood and air and improve the biocompatibility between blood and the materials, all the surface that the blood would become in contact with. With the evolution of the ECLS circuit, there was the first successful case of veno-arterial ECMO in the early 1970s. It was an adult patient. He was 22 years old. He had a motor vehicle crash and sustained many traumatic injuries and had ARDS. If anybody's gone to an ECMO talk, you've seen this man's picture. It really depicts how complex the ECLS circuit was for that time, and how big the equipment was. And then since then, in 1975, Dr. Robert Bartlett successfully treated the first newborn with ECMO, and that really propelled the neonatal and the ECMO, or pediatric world of ECMO. Really, Dr. Bartlett is the father of ECMO. He's been recognized nationally, internationally for all of his work, really setting the stage for why we use ECMO today.
You had a perfect lead into my next question, because when you look into the literature and you start to research this, you see two terms frequently, right? You'll see ECLS and ECMO, or ECMO, frequently. So since the listeners may see or hear these two terms not only in this podcast but also in the literature, what's the difference between those two terms?
Yeah, that actually is an excellent question, and my feeling is a lot of people use ECMO as the broad umbrella blanket term, but that actually is incorrect. ECLS, or extracorporeal life support, really should be used to describe the entire family of extracorporeal support modalities. So really, that's your overarching or umbrella term, is ECLS. ECLS then is divided into the two different modalities, which includes Ecmo, extracorporeal membrane oxygenation, and ECOR, which is extracorporeal carbon dioxide removal. So as I mentioned, everybody just kind of says Ecmo, but that actually does mean one specific type of modality, because as other extracorporeal applications have emerged, they're actually not considered ECMO. As I mentioned, the eCore is not considered ECMO, it's its own entity. And so for those listeners who really want to grasp on what term really goes with what modality you're using, there was an excellent international consensus statement that was published in early 2018. Well, excuse me, it was probably mid 2018, which really established nomenclature in terms of these abbreviations, definitions, and cannulation descriptions. That way we have consistency when we talk clinically and also in terms of research as well.
What a great explanation. Okay, so ECLS is moving forward in the episode. That's what we will refer to it as here. So I guess why are we talking about this today? And I'm asking that because if you looked at the published literature for ECLS and ECMO, I'm not sure you would get blown away with the positivity or the results. Would you agree?
True.
So what is it that is there something happening that is, putting this into the forefront of a lot of the critical care kind of world?
Yeah, I guess it's a difficult question, and maybe I just need to walk through maybe some of the history and what's born out of ECMO. So, as I mentioned, the first successful case was in the 1970s, in the early 1970s, and then the first randomized controlled trial came out in 1979, which really put a real big damper on ECMO when they compared veno-arterial ECMO in adult patients with severe ARDS. And looked at survival rates between the two groups. They were very dismal. They were about 10% in both groups, with major complications in the ECMO arm. And so subsequently, really ECMO for adult patients was really just relegated to a few centers. And largely when you look at publications between 1970s and about 2009, it's really just case series. And part of that was there had to be an evolution of the ECMO circuit, as I already mentioned. And because of the improvements in the technology, there was a resurgence with the use of ECMO. And it's right at that 2009. Two things happened. You guys previously talked about the Caesar trial on your ARDS podcast, so I won't go into that with great detail. But it did favor ECMO, although there are a number of limitations within that trial. It's I think reasonable to say that patients should be transferred to a center that could put a patient on ECMO. Those are kind of the results I get from the Caesar trial. But the second is ECMO there was widespread use because of the influenza pandemic that happened that year. And so when you graph out, the Extracorporeal Life Support Organization publishes the use of ECMO as well as the number of ECMO centers. And really, there is this line at 2019 that is this steep inflection. And we see this volume rise because people were now using ECMO for respiratory failure as well as cardiac ECLS. And again, that's the evolution of the circuitry. And then, of course, most recently, we had the EOLIA trial, which at face value is a negative trial. But when you start to dig deep, as you talked about in the last podcast, there are some positive results of this trial suggesting that there is a mortality benefit to ECMO in patients with very severe ARDS as they were defined by the EOLIA criteria. And so equally too, if you simply mapped out all the publications, regardless positive negativity, because there's so much use, there's so much interest in outcomes and complications, and us as pharmacists thinking about what is the extracorporeal circuit doing to our medications, that once again, if you map out all publications, there's this huge inflection that happens at 2009, and a lot of it is coming from the adult population because that's where you saw this resurgence of the use of ECMO.
Now, I think I may have put the bull in front of the horns a little bit because we're kind of talking about how it's, how the use has grown, its history. But I guess maybe first we might want to kind of address what exactly does ECMO do? What's the physiology kind of behind this advanced therapy?
Sure. I think in the most simplistic terms, it's oxygen delivery, carbon dioxide removal, and circulation of oxygenated blood. And you can support the respiratory system alone, or you can have a combination of supporting the circulatory and respiratory system. So you have blood that drains out from the patient, which is typically called your venous drainage catheter. And then the blood is going to a semi-permeable membrane. In this case, you're separating the blood from the gas compartment, and you're allowing the gas to diffuse between those two compartments. Deoxygenated blood, then it becomes oxygenated, the carbon dioxide is removed, and that returns back into the patient's body. So once again, depending on what modality you're choosing, you can either just support the respiratory system, or you could support the respiratory system and the cardiovascular system.
What different modalities are there? Focusing kind of specifically on ECMO, I think we'll kind of leave the E-core side of it out of it, but the different modalities of ECMO.
Yeah, excellent question. So there are three broad categories, two of which I will talk about. VV ECMO, or veno-venous ECMO, is when the drainage and reinfusion cannula are both located in central vein. So you're going from a vein and reinfusing in the vein. This is only providing gas exchange support to the patient. So the typical indications would be for those patients with respiratory failure. Oftentimes, status asthmaticus could also be placed on VV ECMO, patients with end-stage lung disease for bridge to transplantation. Now, VA, or veno-arterial ECMO, is when blood is drained from a vein and then reinfused into an artery. So in this case, you're providing both gas exchange and circulatory support. And here's where you have a plethora of indications for VA ECMO, which could include some such as cardiogenic shock, massive myocardial infarction, fulminant myocarditis, pulmonary hypertension, massive pulmonary embolism. And then where we've seen a lot of VA ECMO more recently being used is in cardiac arrest, or otherwise called ECPR.
And I think we'll talk about the general management and maybe depending on the modality, different emphasis, a different focus on different interventions. But before we get to that, in a standard ECMO setup or configuration, what equipment is involved?
Sure. With the ECMO circuit, you have three primary components. What I like to think of is you have the blood pump, which is taking your blood out, putting it back into the patient. But more importantly, you have your gas exchange device that the pump is pumping the blood to, and your heat exchanger. Now, all of those three components are connected by standard medical grade tubing. So first, focusing on the tubing, because I think as pharmacists, this is what creates probably the most problems for us with dosing, especially of antibiotics and sedation, is that the tubing is quite large. When I'm consenting patients' family members, although it might scare them, they do equate it to almost like a garden hose, the size of a garden hose in terms of its diameter. And it's quite a bit of tubing that's used to connect all of these components. But the blood pump, it's a dedicated centrifugal pump, and that's oftentimes driven by electromagnetic induction motors and uses the principles of centrifugal force to generate a flow. Now, the flow is going to depend on the speed, or oftentimes we note that as rotations per minute of the centrifugal pump. Your RPMs might be dictated on your hemodynamic conditions, how volume up the patient is, what their preload is, what their afterload is, how large the cannulas are, where the cannulas are placed, etc. Now you have your gas exchange device, oftentimes referred to as your oxygenator for short. And here you have the fraction of delivered oxygen in the sweep gas. often referred to as FDO2, and that's controlled by a blender. So this, if I was to equate this to mechanical ventilation, it would be titrated just as you would the FiO2. But instead, you're talking about delivered oxygen, which comes with a sweep as well. And so the faster the sweep, gas is propelled through the membrane, then the quicker the CO2 is removed. So that's what's happening. That's where all the magic is happening within the Ecmo circuit, within the oxygenator. Now, of course, because there's so much extracorporeal blood, that blood is exposed to the ambient air and actually is cooled down. And so within the oxygenator, you're going to rewarm that blood before it gets placed back into the patient. Otherwise, you would be dealing with a patient which would be substantially hypothermic. And obviously, we don't want that. Now, those are the basic circuit components. There are certainly other bells and whistles that you can add on, including shunts. So oftentimes that's referred to as bridge lines or recirculation sites. You can have connectors that assess oxidation saturation measurement systems, bubble detectors, and other types of alarms. The more you're adding to the circuit, the higher propensity you are for areas of clot to form. It's more plastic, so more drug may adhere to the surface. So I think most centers are looking at just keeping the circuit as basic as possible, which is those three primary components, and then, of course, the tubing to connect them all.
That makes sense, because the more complicated you make an already complicated procedure, right, in an emergency, that just allows, potentially more rooms for not necessarily mistakes, but, just delays in setting that up and hooking that up. So that the KISS method is probably a reasonable strategy there.
Yeah, and many of the components that can be added, I think, give centers that are not as familiar with Ecmo a sense of security to detect air in the line, to detect if there's clot. But if you're a center that has a good team, you're looking out for those things and will sometimes detect that before any of the bells and whistles would probably have detected.
Now you did a great job of running through a lot of the big indications for ECMO, and this is a very evolving topic. But are there things, maybe focusing on VA ECMO, are there things that get tried before patients get placed on ECMO, or are there times where, just based on the severity or the indication, they'll go straight to being cannulated for ECMO?
I think that's a multidisciplinary approach question sometimes. I'll try to break that down. I think first and foremost, I want to impress upon the fact that ECMO is not a way of life. You have to have an end game, because ECMO is not destination therapy like you would consider an LVAD or a BiVAD. People can't go home on ECMO. So before placing somebody on ECMO, it's really important to have these conversations of what's the end game. So I'll give you an example. If somebody has a pulmonary hypertension crisis, is the end game they will recover? Are they good protoplasm that they will be an ECMO candidate and they will recover? So that would be bridge to recovery. Or a VV ECMO patient with severe ARDS, will they recover? So bridge to recovery. Sometimes our PH patients are already on the lung transplant list, so they would be bridge to transplant. So you always have to have an end game. Now, possibly if you're conducting ECPR, well, you don't know the end game yet, but this is a patient who you've thought about. They don't have many comorbidities. It makes sense that they need this extra support in order to correct the underlying problem. So to answer your question, sometimes it's thought about. If you know that this patient is on the precipice of decompensation, you will start having multidisciplinary talks on, is this patient an ECMO candidate? Because you want to be thoughtful about perhaps getting these lines in place and thinking about it, because you never want to emergently put somebody on ECMO if you don't have to.
That's a really good. Yeah, go ahead. I'm sorry.
No, no, please.
I was just going to say that's a really good point because for some of our other, advanced modalities, such as, for example, if someone's placed on CRT, they can go home on intermittent hemodialysis, right? If somebody gets placed on the ventilator, they can go to a long-term facility that can deal with, ventilator management through a trach and things. But this is a unique scenario where you can't, like you said, you can't go home with this therapy.
Right, and you know, we've made such strides with ECMO or ECLS in general, moving it out of the operating room, such as cardiopulmonary bypass, and allowing for extended periods of time. But we're still not at that point where we can be on for half a year or a year. I think in my lifetime, I probably will see the portable ECMO circuit. I have a feeling I'll be dabbling in that, but unclear.
So drug dosing in these, special patient populations, I think is a cornerstone intervention for a lot of critical care pharmacists and just critical care healthcare professionals in general. And I'd have to say that, ECMO is no exception. So how does, ECLS or ECMO affect, the pharmacokinetics and pharmacodynamics, maybe compared to just general critically ill patients? Because we know they have changes in their PKPD as well.
Sure. Well, anybody who has heard me talk about ECMO, I go to this triangle that has a person in the middle of this triangle, and I go to the basic and thinking about when you give a drug, regardless if this patient's on ECMO or not, there's this balance between the dose that you're giving the patient and the elicited response. And your total goal is you want to provide a therapeutic effect while minimizing toxicity. But there's a lot of factors in between giving that dose and finding out what the response is going to be that can influence that drug concentration. That can be drug characteristics, just the disease itself, and then, of course, the addition of extracorporeal factors. And so understanding how all of these interplay with each other can help guide you to make more appropriate pharmacotherapy recommendations, because there isn't a whole lot of literature on how to treat these patients or what to do when they're put on ECMO. There is a lot of information, though, about the pharmacokinetic alterations just in critical illness, and we could probably talk a whole hour about this, but I will keep it brief and maybe just highlight some of the more important ones. Patients who get large volume resuscitation will have leaky capillaries and have a larger volume of distribution because of that. And so you may see decreased plasma concentrations, specifically to those drugs that are water-loving drugs. They will get more dilute with the increase in volume of distribution and therefore decreased plasma drug concentration. We're going to see altered protein binding. And of course, that goes for decreases in albumin. And then you have increases in alpha-1 glycoprotein. So again, you might vacillate between having decreased or increased plasma drug concentrations depending on how protein bound that drug is. And then, of course, I think what keeps us in business is all the end organ dysfunction that we deal with, renally adjusting meds, potentially hepatically adjusting medications. But you will see decreased clearance with end organ dysfunction and potentially increased drug plasma concentration and potentially leading to toxicity. Some of those same alterations may be seen with the addition of the ECMO circuit, including you might see some augmented cardiac output, you might see some end organ dysfunction. But there's really two important concepts with the addition of ECLS. The first one is hemodilution. And that's probably more related to ECMO because your circuit is primed with something when you're connecting it to the patient. So you're inherently giving them a large volume of distribution. Now, whether your priming material is using balanced solutions, albumin, or blood, you're still giving back volume. And so if you're using a water-loving drug at the initiation of ECMO, you're going to see hemodilution because of the increased volume of distribution. So, for example, an aminoglycoside, there are some studies that demonstrate within the first 24 hours of the initiation of ECMO, you're not able to achieve the peak concentrations that you would need to because you've hemodiluted the aminoglycoside, and and therefore you may have to adjust your dose, at least at the initiation. But when I think about ECMO, I think more importantly about a concept known as drug sequestration, because not only does that happen at the initiation of ECMO, but also throughout the ECMO run, and that can lead to potentially substantially decreased plasma drug concentration. So if I'm to talk just a little bit about what does drug sequestration mean and where is it occurring, I think by and large, as I've already talked about, the ECMO circuit is composed of a lot of tubing, and that tubing is made of polyvinyl chloride. And we know as pharmacists from pharmacy school, there are certain drug characteristics that will attach to polyvinyl chloride. But when you think about the adult ECMO circuit, that is a huge surface area. Lots of opportunity for those drugs to coat that surface and decrease the concentrations that actually get to the patient. Now, the membrane oxygenator in the past was a culprit of drug sequestration. The silicone material that was used in more of the neonatal and pediatric ECMO circuit way back before 2009, that tended to sequester drug, but now using more newer membrane oxygenators, which is made of polymethyl pentane, they seem to not sequester too much drug. But again, as I mentioned, as you add more bells and whistles into the ECMO circuit, you're adding more plastic, you're adding more potential sites for drugs to be sequestered within the circuit. And then lastly, thinking about what priming solution you're using. If you're an institution that's using balanced solutions, that's probably your least effect maybe on certain drugs. If you're using albumin, thinking about if you're starting an ECMO run in a patient, you're giving a highly protein-bound drug, you may consider redosing it if you can hold off, dose it a little bit later because you're introducing at least a substantial amount of albumin to the patient. So all of these factors play in. Of course, we don't know necessarily how much one is contributing over the other. We can make speculations, but this is a huge area for research to find out what are the extracorporeal factors that really played the biggest impact. Now, in my last part of the triangle are the drug factors. Probably the two most important drug factors that help out with drug sequestration is the lipophilicity of the drug and how protein-bound the drug is. So essentially, if you're dealing with a high protein-bound drug, it is more likely to be sequestered within the ECMO circuit. Same concepts apply. The more lipophilic the drug is, the higher likelihood the drug will be sequestered into the circuit. Now, as pharmacists, we know very quickly where to find protein binding in any pharmacopoeia we can look at. It's right there in our face. But the lipophilicity of a drug isn't necessarily always there. And so you can go to any drug bank and you can look at the octanol water partition coefficient or the log P value, and that'll give you a sense of how lipophilic a medication is. So if I was to give the example of propofol, in my opinion, propofol is the epitome of a lipophilic drug. It has a log P value of 4. So the closer you are to 4, the higher likely that the drug will be to some degree sequestered within the circuit. When you compare that to something like hydromorphone that has a log P value of 0.9, that's probably less sequestered within the circuit just based on that log P value.
And not only can you look for that information in drug references, but I certainly want to highlight your recent publication in pharmacotherapy. It discusses some of these pharmacotherapy strategies for ECLS, and it's an absolute must for everyone's library. And there's a fantastic graphic that visually shows the medications, in relation to their, protein binding or lipophilicity. So especially for the visual learners out there, it's a gem of a resource for everybody. And I think a lot of the things that you just highlighted, it's concerning certainly for all of the drugs, but I think even more for those that we can't measure their efficacy, right? The titrate to effect medications, you will get to doses that may make us uncomfortable or open patients up to potential adverse effects. But like you mentioned with the aminoglycosides, there's not we don't have great ways to know if it's actually getting to the site of infection. And that's when that can be really, really concerning.
Absolutely.
So based on all of these, the PK/PD changes in these critically ill patients, I think if you have an ECMO, if you are at a hospital that is running an ECMO program, I think almost everyone would agree to have protocols in place to ensure kind of safe and effective pharmacotherapy, for these patients. So I think what might be helpful would be if we can kind of go through what we kind of talked about and think are maybe some of the more specific and important protocols and kind of give some tips and tricks. And so we'll kind of focus on anticoagulation, infections, and sedation. So starting with anticoagulation, I think most, and again, I said most here, would agree that ECMO patients require anticoagulation. And then I think the consensus basically stops right there. Now, do we have a best practice in terms of laboratory monitoring for anticoagulation?
Nick, if I had the answer to this question, I would be a millionaire, I think. We meet monthly to discuss our anticoagulation practices at my institution, and it is you want to pull your hair out when you leave that conference sometimes, because there is just, the literature is not specific enough. In fact, we felt kind of better. We kind of patted ourselves on the back a little bit, because I don't know if you saw this, but there was about a month ago, a survey that went out to all the ELSO centers. And we all know the limitations of surveys. But I think what was refreshing to hear is nobody across the country, or it was international, knows what to do with anticoagulation. And when you polled people or folks on APTT versus 10A, it was split down the middle. And you threw in maybe some TAG or ROTEM. But it seems to me that ACT has pretty much fallen off the map, I would say, for routine anticoagulation with ECMO. And we're really left with the APTT and the 10A. Now, as appealing ACT is, because it is a point of care test, you don't have to send the lab or the blood to the laboratory, you don't have to wait for the results. It's really nonspecific to the heparin effect. And there are just so many factors, such as deficiencies in platelets or clotting factors, which we know occur with the ECMO circuit, that it just doesn't really give you a sense of how anticoagulated the patient is. So like I said, ACT, I think, has fallen off the map, and then we're left with APTT.
Now, depending on the ECMO modality that patients may be receiving, does the therapeutic goals for anticoagulation differ? And obviously, we could spend a whole episode talking about the specific goals, but I mean more just depending on whether it's VA or VV, does the intensity of the anticoagulation differ?
Yeah, that's a really great question. And I think a lot of centers somewhat struggle with just what goal to pick, because there isn't a standardized APTT or 10A level to choose. But I think the overall arching theme tends to be that you can have lower levels of anticoagulation with VV ECMO and maybe a little bit higher goals with VA. And the reason behind that is, just think about where you're putting that blood back into the patient. With VV ECMO, you're returning blood on the venous side, where with VA ECMO, you're returning blood on the arterial side. So if there was a clot in the ECMO circuit, you're returning that clot or delivering that clot potentially to the arterial side, and that's going to travel right to the brain and potentially lead to some neurological devastating outcomes in that patient. So I think that's why there's that differentiation between your therapeutic goals, between those two types of modalities.
Now, in terms of our empiric anticoagulation, do you personally have a preference to using, unfractionated heparin versus a direct thrombin inhibitor such as bivalirudin? I guess as empiric, as your initial anticoagulant of choice.
Yeah, I think by and large, nationally and internationally, people are still choosing unfractionated heparin as their go-to anticoagulant of choice. And that is actually what's supported by the Extracorporeal Life Support Organization guidelines. I mean, compared to other anticoagulants, unfractionated heparin is preferred because it is a short duration of action. It is relatively easy to titrate, and maybe sometimes more importantly, it is reversible, although not many times do you need to reverse anticoagulation for a patient who's on ECMO. But there are limitations to using unfractionated heparin. Again, the monitoring that we have is not precise, whether you're using APTT or 10A. Of course, APTT is subject to a lot of, you may get different results with APTT because of DIC, low fibrinogen, acquired von Willebrand's factor. Hemolysis may cause your anti-10A levels to also be elevated because of that free hemoglobin. So, I think it's a tough question to answer, but I think by and large, everybody is using unfractionated heparin initially. But as I say that, there is some interesting data that has recently come out with centers that are using bivalirudin as their go-to anticoagulant. As you know, bivalirudin is a direct thrombin inhibitor and therefore doesn't require antithrombin as a cofactor in order for it to exert its therapeutic effect. So potentially in a patient who has an antithrombin deficiency, bivalirudin might get you to therapeutic goal faster. What we do see between the two agents when they're head-to-head compared, mostly in retrospective studies, and so I should retract, it's not necessarily head-to-head, but compared in a retrospective fashion, you see less aberrations with bivalirudin, so less blood draws to monitor. But unfortunately, there's no clinical outcomes that dictates one is better than the other. Bleeding rates tend to be the same. So I think in the light of pharmacy stewardship, bivalirudin is much, much more expensive than unfractionated heparin. And so without those clinical outcomes, it's hard for me to, by and large, recommend bivalirudin carte blanche as the initial anticoagulant of choice.
And that makes sense. That makes sense. So infectious complications can certainly occur in patients receiving ECMO. So what is the role for antimicrobial prophylaxis? I think the first question would be, should patients receive prophylaxis just upon cannulation? Because you mentioned it's a catheter similar to the size of a garden hose going in, or based on that, should it be maybe more for a more extended period of time?
Yeah, that's a great question, and there's not a lot of data looking at antimicrobial prophylaxis at the time of cannulation. I think this is where you're going to have to use your clinical judgment. If you're in the OR and you're under sterile conditions, you may not have to worry about prophylaxis. However, if you are going out to another institution and you're cannulating at the bedside, you may think about giving a dose of cefazolin. So right now, the Extracorporeal Life Support Organization is really just supporting following recommendations for the prevention of surgical site infection. And I tend to agree with that. There may be other exceptions where if somebody has a transthoracic cannulation and an open chest, they are at risk for mediastinitis. So perhaps there is a more protracted course of antimicrobials in those patients. There may be other situations where patients have femoral lines in place. And we know femoral lines aren't the best place to have lines in patients. And so that may pose an opportunity maybe to have some sort of antimicrobials on board. Why I think there's a lack of data is many of our patients who are initiated on ECMO already are on antimicrobials. So it's hard to know, do you add something else with a bigger spectrum? Do you keep them on what they're on? So there's a lot of unknowns in the arena of prophylaxis when being cannulated.
Now, we obviously use the prophylaxis to help prevent infections, but it's unfortunately not 100% effective. So when these patients have, suspected or confirmed infections, should our empiric antibiotic selection, differ from other critically ill patients? I'll use those in, septic shock, for example. Should there be a different empiric selections, or what's your general thought process when encountering this?
Yeah, my recommendation is always when you're suspecting or you're treating an infection, use what you would normally use in a patient not on ECMO. In terms of your choice of antibiotics, look at your antibiogram at your hospital. Maybe look at patients' past cultures. Then, once you've picked your antimicrobial, now you've got to figure out the dose, because here's where one dose doesn't fit all. And I mean, that's clearly obvious from a lot of the research that our colleagues have done, including Jason Roberts, who I remember distinctly published this prospective multi-center pharmacokinetic point prevalence study that just really opened our eyes as to when we use these doses that are approved based on healthy subjects and we apply them to critically ill patients, a lot of the times we can't achieve the appropriate concentrations in order to treat the infection. So now you have your most critically ill patient with potentially more inflammatory markers because now their blood is being exposed to a new surface. And so that inflammation may cause even more aberrations for these antimicrobials, of which there is little data. There will be lots of data coming out, especially from the group in Australia, as they are looking at drug antimicrobial concentrations for patients receiving ECMO. But it's hard to tease out what is actually causing the change in the antimicrobial concentration. Is it just the critical illness alone? Is it the extracorporeal circuit? Or is it some combination of both? And what proportion is contributing more than the other? So my general rule of thumb, I'm always aggressive with antimicrobials, at least the dosing, especially in the first 48 to 72 hours, because most likely the patients that I'm taking care of, the reason why they went on ECMO was because they have an infection. So the success of ECMO is going to be the success of treating that infection. So I will dose large. I don't necessarily all the time adjust for renal dysfunction. I want to get adequate concentrations and hope I'm not doing harm. I think what compounds this is when patients are also on continuous renal replacement therapy. Now you've got two extracorporeal devices, and you really have no clue what concentration. So I look forward to when we are able to have beta-lactams and carbapenem, therapeutic drug monitoring, and can really tailor our pharmacotherapy regimens to our patients.
That's going to be fantastic. I'm definitely on the go big or go home train as well. Now, interestingly enough, the FCCM pain, agitation, and delirium PAD guidelines don't discuss the use of sedation and analgesia specifically as it relates to patients receiving ECMO. Now, this is probably a loaded question here, but what medications should generally be, first line or maybe preferred for patients receiving ECMO?
Yeah, that is a loaded question. I think it ultimately goes back to what is your goal and why is the patient on ECMO? If a patient is bridged to transplant, we don't want to use sedation. We want them extubated on ECMO, walking around the unit, interacting with the environment. If they are bridged to decision because they had a cardiac arrest, we don't want to impair any more neurologic function. We want them to wake up, make a decision. Where I think it gets a little hairier is a patient's placed on VV ECMO for severe respiratory failure. Now, it's kind of all over the board in terms of what we do with these patients. Everybody's publishing on their single center experience. And sometimes they are congruent, sometimes they're mismatched in terms of what results we're seeing. I think ultimately, though, we do see that patients do require a little bit more then those patients maybe not on ECMO. I know how we practice. We give ultra low tidal volumes to these patients. So we will drop their tidal volume to 2, 3 cc's per kilo, and we'll keep going because our end game is to keep that lung at rest. And so in doing so, we can't have them interacting with the ventilator. So oftentimes we do need these higher levels of sedation. But the concepts of the PADIS guidelines really apply, thinking about every day. Do they need to be this heavily sedated? Can we wake them up? Can we lighten things? So all the same concepts apply, even though the ECMO patients weren't necessarily mentioned in the PADIS guidelines.
So I maybe set you up for failure there then in my question of what should be, first line or preferred. Maybe a better way of thinking on the flip side. Are there any agents that we should avoid using?
Sure. So when you think about the sedative agents, again, applying what we've already talked about, is the drug protein bound? Is it lipophilic? And maybe shying away from those agents. But guess what, folks? All the sedatives we have are highly protein bound and highly lipophilic. So there's really no way out of this conundrum. I think to answer your question, should we avoid anything? Well, that's hard to answer. Some people will emphatically say avoid propofol because it's going to clog my circuit and I'm going to have to change out the circuit, which is costly, it's dangerous, etc. Although there are 2 now retrospective publications on the use of propofol. And when you compare the patients who didn't receive propofol, we don't see that over 7 days the circuit is compromised. And we've used propofol quite extensively here, and I have also not observed that. So I think the literature is pointing towards, propofol might not be as dangerous, but thinking about, well, where I would normally use 20 mics per kilo per minute to achieve the same RAS or SAS goal, I might need to use 40 or 60 because some of it might get sequestered in the circuit. That's the nice thing about sedation is you set an endpoint and then you can titrate to get to that endpoint. Now, of course, the PADIS guidelines would suggest avoiding benzos, and I wholeheartedly agree with that. But perhaps you have a hypotensive patient who needs to be sedated, so propofol is out of your mix, then you are kind of stuck. In order to achieve a RAS of -4, -5, you're going to ultimately need a benzodiazepine infusion. Dexmedetomidine just won't get you there. But using dexmedetomidine to help wean, get the patients more awake when their lungs have healed, you're starting to take support away from the ECMO circuit. I think that is a good practice.
For anyone needing any help with protocols or improving their ECMO kind of program, that was a gold mine of information there, Amy. So that was fantastic. Now, the longer you're involved in the care of patients on ECMO, I'm sure you can see the spectrum of possible adverse effects. But what are maybe some of the most common complications or things that we should really have our eyes and ears out for?
Yeah, I think I would go with what the Extracorporeal Life Support Organization publishes. And I would say based on that registry, bleeding is always the number one problem. Not only because you're giving this patient an anticoagulant, but they also have consumption of their coagulation factors, so they are at very high risk for bleeding. And I think the second most common medical complication of ECMO is infection. Oftentimes these patients are not mobile and they are at increased risk because they have multiple catheters placed in them, maybe ventilator-associated pneumonia if they're concomitantly on a ventilator. I think it's hard to. I think those are probably the more frequent ones, but maybe not the most devastating ones. The most devastating ones would be your neurological complications, including CNS infarction, your pulmonary, perhaps pneumothorax that eventually doesn't lead to good healing. So those are infrequent, but they can be more devastating. So having a multidisciplinary team looking out for all of these potential complications and knowing how to manage them. If anybody has gone to the ELSO simulation, it is a 3-day simulation intense. It's almost 10 hours a day, but it is awesome. When you go there, they repeatedly say this quote, and it's 99% of ECMO is boring. But it's that 1% that, man, you have to know how to react in order to continue to save that patient's life and apply appropriate resuscitation or, fixing the problem, whether it be mechanical or medical.
That's a fantastic quote, and so true probably for many other things as well. Now, as the use of ECMO, I think, will continue to increase, I think there's likely a lot of listeners who, may be tasked with help implementing, ECMO-specific protocols or, being on the kind of team to help, work on the, maybe QI of the current ECMO program. So what are some general steps or some things that you've learned in your time that you may be able to help others with if they're tasked with kind of protocol development or improvement?
I think the best piece of advice that I could give is get your multidisciplinary team together. Your nurses, obviously us as pharmacists, your clinicians. Sometimes institutions will have separate ECMO clinicians versus the intensivists in the ICU. And just get everybody on the same page, regardless of what you choose to do or what you think is the best practice based on what your needs of your patients and also going off of non-ECMO guidelines. Choose what you're going to do and try to be consistent, because I think that's the most important. Of course, every patient's different, and I'm not suggesting to make it cookbook. But if you have a guideline in place for sedation for your mechanically ventilated patients, think about, well, how can I tweak that guideline and everybody's on the same page to treat the different types of ECMO patients that I might see, whether it's respiratory failure or whether it's bridge transplant. How would I treat each patient differently? And get everybody on the same page and how they will monitor what you're going to use. It's important to pick what you're going to use, but also equally as important is how do you monitor for appropriate effectiveness of that drug and the toxicities, because we might be using higher doses than what we would normally be well versed in. And so it's important to be in tune with what might be different in this patient.
That's awesome kind of help or tips there, and I think that also carries to things, non-ECMO, because with a lot of these, especially when you're living in the gray, like we do with a lot of critical care, and there's many ways to do things. If you don't have a set protocol, then you can be, getting into discussions about what's best to do rather than, giving that prompt, effective care when there's, many different ways to do things.
Exactly.
So are there any studies or kind of general broad areas of ECMO research that we should be keeping our eyes out for coming out on the horizon?
Well, I think the biggest, the studies I'm waiting for are the Australians have their, all of the drug levels that they are looking at, from sedatives to opiates to antimicrobials. And I think little by little we're seeing pieces being published, but I have a feeling we're going to wake up one day and Jason Roberts and his colleagues out there are going to go, bam, here's what we found. And we're either going to be blown away because it's not what we expected, or it's going to be consistent with what we've already thought. I know that there is also a major anticoagulation trial that is going on at large ECMO centers, and that will also be very revealing. I'm not quite certain what the different arms are, but it is going to compare different modalities of monitoring, and that's going to be a long way off, though. That's probably going to be in the next 5 years. And so what I always joke about, when that gets published, we'll have just figured out what's good for everybody's center, and then we're going to have this publication and rethink everything again. But I guess it keeps us with a job.
That's you're probably extremely accurate on that, though. Now, this may be hard because you've really done an amazing job of kind of walking us through ECMO and talking about so many of the details and intricacies in this advanced therapy. But if you had to emphasize, a few important points or some of the things that you think are most important, what would those points be for our listeners?
Well, I think in terms of antimicrobial management, always remember that source control coupled with timely and appropriate antimicrobials is key. Look at your published pharmacokinetic data in the critically ill patient to help make and guide your dose adjustments, because if you look up cefepime and ECMO, you're not going to find a whole lot. So look up cefepime in critical illness and think about, how do I dose adjust, because 9 times out of 10 you're going to be giving a higher dose than what you would in a normal healthy person. And use therapeutic drug monitoring whenever you can, although some institutions may be able to monitor beta-lactam and really tailor the therapy. But if you can't, and it might come to your institution soon, set those protocols up, because it's very important to make sure we're treating all infections in all patients. In terms of sedation, I think really applying the PADIS guidelines, thinking about who is your patient population. As I said before, your patient with severe respiratory failure, that's really where you're going to be applying the PADIS guidelines, establishing your sedative goals, thinking about when can you interrupt sedation, when can you wake them up. And then when you're decannulating the patient, think about significant dose reduction at that time, and always monitor for signs and symptoms of delirium or withdrawal, because we actually don't know what we're delivering to the patient. We may be overshooting and then having this higher propensity of delirium and withdrawal. And then in terms of anticoagulation, I think this is just an opportunity where institutions can decide what monitoring best fits them, because there is no precise and accurate test at the moment. I think we're going to learn a lot with TAG and ROTEM coming out. We may be able to apply that to ECMO patients. I think we have to tread cautiously at the moment because we don't have a lot of information, but that might actually help improve outcomes in terms of understanding the clotting and the coagulation cascade.
Amy, this was fantastic. Thanks so much for coming on and really sharing your plethora of knowledge with myself and the audience. So what's your Twitter handle so the listeners can follow you on social media?
It's at Amy Dzierba. No spaces, just all one word. Should I spell my last name?
No, they'll see your last name spelled everywhere with the episode release. So I think that's okay. That's nice. Okay. You don't have to have any underscores or numbers. You got I feel like that's one of the advantages of having a unique last name. But I'm sure you're used to being called everything under the sun, right?
Yeah, but that's okay. Whatever you want to call me.
Well, thanks again, Amy. We really appreciate it.
Well, I can't thank you enough. It was an honor to record this with you, and I appreciate the opportunity. And all these podcasts are so great. So I encourage every level of learner to listen to them because they've all been excellent thus far, and I look forward to all the rest of them.
Well, that means a lot. Thank you so much. Thank you so much. And another huge thanks to Amy Dzierba for taking the time to join us today. And we also want to give a massive thank you to you, the listeners, because obviously this podcast doesn't exist without you. So please send me feedback, both positive and negative, as well as any guest or topic ideas via Twitter or Instagram at PharmacyToDose, that's TO2Dose, or via email at PharmacyToDose@gmail.com. And as always, on our website, PharmacyToDose.com, you'll find the show notes for this and all previous episodes that are going to include background reading, guidelines, some of the articles that Amy and I talked about in this discussion, and much, much more. So honestly, I'd love to hear from each and every one of you. And I'm really, really excited for what's to come in 2020 for this podcast and you, the audience. So until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.